Hi everyone, welcome to today's quarantine clinic. Today we'll be discussing vestibular dysfunction. Now, vestibular dysfunction is a very important topic, but it is not often discussed. And whenever you get a patient of giddiness or vertigo, it is difficult to analyze initially unless you have some fundamental knowledge of how the vestibular system works. So when we discuss how to approach a case of vestibular dysfunction, it is very important to know the anatomy of the vestibular system and the connections of the vestibular system with the rest of the brain. So that is where we will be starting with. First, let's talk about the anatomy of the vestibular system. So fundamentally, the purpose of the vestibular system is to maintain balance. So imagine if there is a person and that person is sitting, walking at any given point, that person needs to know in what direction his body is oriented with respect to gravity. So this is the fundamental need of the organism, that you need to know whether are you upright, are you upside down, and how quickly are you moving, are you accelerating or are you slowing down. This entire information is given to the brain by the vestibular system. And the way it does it is that there are two vestibular apparatuses on either side inside the ear next to the cochlea. So the cochlea is the part where you hear from, and right behind it is the vestibular apparatus, which tells us about our orientation. So now let us look at the anatomy of it. If this is the ear and you have the auditory canal, and here you have the malleus trapezincus bones, and then you have the cochlea, the vestibular system is posterior to it. And the vestibular system is essentially composed of three things. One is there are three semicircular canals. There is something called as utricle. There is something called as saccule. And this connects it to the vestibular nerve. And there is also an endolymphatic sac. Now, I'll tell you what each of these parts does, but understand that this entire area, this whole thing, the sole purpose is to provide information regarding the orientation of the head with respect to gravity. Okay, so let's take it one by one. Vestibular apparatus consists of semicircular canals, utricle, and saccule. Now, the utricle and saccule part is easier to understand, so I will talk about that first. Utricle is a horizontal structure and saccule is a vertical structure, and both of them contain endolymphatic fluid. And the reason that there is fluid is because inside both utricle and saccule and inside the semicircular canals also, there are these structures called as hair cells. And what happens is that if there is movement, the endolymphatic fluid moves. And when the endolymphatic fluid moves, these hair cells get stimulated. And depending on the direction in which they are moving, you know whether in which direction the fluid is moving. And depending on which direction the fluid is moving, you know in which direction the body is moving. So the utricle will tell us about horizontal movement, so horizontal acceleration and deceleration. And the saccule will give us an idea of vertical acceleration and deceleration. So if you are in a lift and the lift suddenly shoots up, it is the saccule that will tell you that you are accelerating upwards. And if you're in a car and the car goes from 0 to 60 kilometers an hour in 4 seconds, that sensation of being pushed back, that feeling will be given to you by the utricle. So if you think about it in terms of axis, your anteroposterior axis is utricle, and your vertical axis is saccule. So this is two main directions that our brain now has an idea about. What about the rest? So the rest, all the directions is the information comes to our brain through the semicircular canals. Now there are basically three semicircular canals, and again you can think about it in terms of an XYZ axis. So the three semicircular canals will give us, put together, will give us an idea about in which direction is your head turning. So roughly you can think of it as three semicircular canals like this. And since there are semicircular canals on both sides, you can, for the sake of better understanding, you can think about it in this image. So now there are three semicircular canals on one side and three semicircular canals on the other side. And if all of these put together will give us an idea of, is your head turning to the right or left? Is your head turning forward or backward? And is your head turning from the side to side? So as and when your head turns, the fluid inside all the three semicircular canals on both sides will move in a particular way. And all that information will be put together to give us an idea of in what orientation is your head with respect to gravity. So what are the three semicircular canals? Let's just take on one side. The three canals are, one is horizontal, also called as lateral. Second is superior, also called as anterior. And third is posterior. So these are three semicircular canals. There is one that is horizontal or lateral, one which is superior or anterior, and one which is posterior. Now, couple of things to remember about these three. The horizontal or lateral one is the only one that lies horizontally. The other two, the anterior and posterior, both are vertical. And coming to which semicircular canal gives us which information about which movement, the horizontal or lateral one will give us information about our this movement, the one when we say no. So this movement, because it is happening in the lateral plane, the horizontal or the lateral semicircular canal will give us the idea. The superior or anterior one will give us the information about this movement, the yes movement. And the posterior one will give us information about the lateral neck flexion. So when your ear touches the ipsilateral shoulder, which is called as lateral neck flexion, that movement is told to us by the posterior semicircular canal. And if it is an angular movement, if you're turning your head at an angle, then there will be multiple semicircular canals giving us the information. So your brain is continuously putting together all the information to give us the idea of how is your head moving. And you can understand how important this is from an evolutionary perspective, that knowing in which direction your head is facing is very important for both looking for food, looking for prey, or looking for a predator. So this is a very primitive part of the brain, and therefore it is highly developed. And there is a lot of connections from the vestibular system to the rest of the brain. So now let's look at the connections of the vestibular system. So assuming that this is the three semicircular canals, then you have the utricle, and then you have the saccule. And from all of these, you have the vestibular nerve. And the vestibular nerve will link up with the cochlear nerve to form the vestibulocochlear nerve, which is cranial nerve 8. So this is cranial nerve 8. So when we say cranial nerve 8, we actually mean two nerves put together. One nerve comes from the cochlea and one nerve comes from the vestibule. And they both give you two different sets of information. The cochlea gives you information about the sounds that you hear, and the vestibule gives you information about the orientation of the brain. And the only similarity between these two is that both of them contains hair cells. In the vestibule, the hair cells are stimulated by the endolymphatic fluid. So the movement of the endolymphatic fluid will stimulate the hair cell, and therefore you know which direction your head is moving. And in the cochlea, the hair cells are stimulated by vibration. So different areas of the cochlea are stimulated by different frequencies. And that is how you hear sounds. That is how you can differentiate sounds. So both of them will go together as cranial nerve 8, and it will enter into the brainstem. Now, within the brainstem, so this is midbrain, this is pons, and this is medulla. The area where the cranial nerve 8 enters is the pontomedullary junction. Okay. Now, once it enters into the pontomedullary junction, the cranial nerve 8 has two separate pathways. One pathway is for the cochlear part of the cranial nerve 8, and one pathway is for the vestibular part. Now, for the sake of completion, I'll just tell you the cochlear part of it, and then we will focus on the vestibular part. So the cochlear part of cranial nerve 8, the structures that it will pass through is 8th nerve. It will lead to the cochlear nucleus in the brainstem. Then from the cochlear nucleus, it will go to the superior olivary nucleus. From the superior olivary nucleus, there is a structure called as lateral lemniscus. This lateral lemniscus will lead to inferior colliculus. I will tell you the importance of this in a minute. From the inferior colliculus, it will go to the medial geniculate body of thalamus. And from the thalamus, it will go to the temporal cortex. Now, the importance of some of these is that the inferior colliculus is a part in the midbrain. So there are two collicula in the midbrain, the superior colliculus and the inferior colliculus. The superior colliculus is the part where your visual pathway is there, and inferior colliculus is for the auditory pathway. And both of them put together forms the area called as tectum. So this is called as tectum. And the function of the tectum is to control your neck movement in response to any threat or any sudden stimuli. So imagine from an evolutionary perspective, you could either see a predator or you could hear a predator. And it is very important to quickly localize where it is coming from and turn your head and turn your eyes to that threat. So it is part of the tectum, the role of the tectum to do this. So this is why it is in the midbrain. So it is a very primitive part of it. And so your auditory impulse also goes to the inferior colliculus. There is a mnemonic that you can use to remember this pathway of the cochlear nerve, and that is called as E. coli MC. Okay, so E. coli MC is 8th nerve, cochlear nucleus, olivary, lateral lemniscus, inferior colliculus, medial geniculate body, and cortex. Okay, so E. coli MC is a mnemonic that you can use to remember the pathway of the cochlear part of 8th nerve. Now let's talk about the vestibular part. So what happens to the vestibular part of the 8th nerve? Again, it will leave the utricle, the saccule, it will end up in the brainstem. In the brainstem, just before it enters into the brainstem as the vestibular nerve, there is a ganglion known as Scarpa's ganglion. After it passes through ganglion of Scarpa, it will end up in the vestibular nucleus, or rather vestibular nuclei, because there are four vestibular nuclei within the brainstem in the pontomedullary junction. Those four vestibular nuclei are superior, inferior, medial, and lateral. And there are four of them on either side. And the function of these four are to then distribute whatever information the vestibule has got. It will distribute this information to all the places that needs it. So supposing if this is the brainstem, and now I'm drawing a coronal section. So this is the midline. So now let me draw the four nuclei. There is a superior one, there is a lateral one, there's an inferior one, and a medial one. So this is superior, lateral, inferior, and medial. Now these four nuclei together form the vestibular nuclei, and from these four, all the nerves will exit and go to different places. So now coming to what are the connections of the vestibular nuclei. And one way to think about this is what all areas would be interested in knowing the information that the vestibule has got. So the vestibule has got information about orientation of the head. Now, what all areas of the brain will want to know that? So the part of the brain that uh, is involved in movement, that would definitely want to know in which area are you facing. So that is the cerebellum. So one of the key areas of connection with the vestibular nucleus is cerebellum. What other part would want to know? Your eyes would want to know, because depending on where your head is turning, your eyes will also have to move accordingly. So if you are looking at a particular point and your head is turning from one side to another, you are still able to keep your eyes focused on that point. And the reason is that your eyes are continuously getting information from your vestibular nucleus that your head is turning in what speed. Because if your head is turning to the left at a speed of say 1 centimeter a second, then your eyes have to turn to the right at the exact same speed. So there is a very close connection. So your oculomotor system also has strong vestibular connections. What other part will want to know? Your spinal cord will want to know, because your muscles are, if you're supposing you're walking and your vestibular system is not connected very well with your motor movements, then you will have imbalance in walking. So there is a strong connection with the spinal cord. And finally, there is connection with the cortex. Out of these, your most important connections are with the cerebellum and oculomotor and spinal cord. So the cortical connections of the vestibular system are not very well described yet, but today we will be discussing the three main cerebellar, ocular, and spinal cord connections. So what is the cerebellar connection? So the vestibulocerebellar connection, there is actually a to and fro connection. So the cerebellum also communicates with the vestibule, and vestibule also connects with the cerebellum. And to cut a long story short, you can have direct fibers and indirect fibers, and both of them will end up in the deep nuclei, the fastigial nucleus. Okay, and it is part of the flocculus. So it is in the deep part of the cerebellum, and the connections will go as part of the mossy fibers. So if you remember our cerebellum discussion, we discussed that there were two ascending fibers into the cerebellum. There's two input, one is climbing and one is mossy. So part of the mossy fiber input into the cerebellum is from the vestibule. And there is a return pathway also. So there is cerebello-vestibular. So the fastigial nucleus will give feedback back to the vestibular nucleus, and this is through something known as uncinate fasciculus. Just remember that there is a close connection between the vestibule and the cerebellum. What about the oculomotor? Main connection with the oculomotor is through medial longitudinal fasciculus. Now, from our discussion of the of eye movement, you may remember that in the brain, you have your third nerve nucleus. So cranial nerve 3 and cranial nerve 4 are in the midbrain, and cranial nerve 6 is in the pons. Correct? And the connection between cranial nerve 3, 4, and 6 is by this tract of fibers known as medial longitudinal fasciculus. I would ask that you go and revise that discussion once, so then it will become clear to you how the brain will control eye movement. So it will control the sixth nerve nucleus, and from there it will cross over into the medial longitudinal fasciculus, go up, and then control the opposite cranial nerve 3 and 4. Now, the interesting part of medial longitudinal fasciculus is that it is not just between cranial nerve 3 and 6. In fact, it extends all the way down to the medulla and even further down to the upper cervical cord, and it even goes down up to the upper thoracic level. So the medial longitudinal fasciculus is a very big structure, and it goes down all the way. And as it goes down through the medulla, what else is there in the medulla? You have your vestibular nuclei. And here the vestibular nuclei will talk to the medial longitudinal fasciculus, and via the medial longitudinal fasciculus, it will give information into the oculomotor system. Now, this connection is very complex. There are other nuclei involved as well, but for the sake of today's discussion, just know that the vestibular nucleus is a strong connection with the ocular motor movement. And finally, with your spinal cord, there is something known as vestibulospinal tract. And there are two of them. One is medial and one is lateral. Okay, now that's enough of theory. Let's go to the practical aspect of it. How does the vestibular system function? The primary function is that in a person, if there are two vestibular systems on one on either side, both of them work together to maintain balance. And the way they do this is that both of them push. So what do they push? All the things that you need to maintain your body in a straight line. So you need to maintain your eyes, you need to maintain your head, and you need to maintain your body. So the vestibular system will push both eyes, it will push the head, and it will push the body. Now, supposing there is loss of one-sided vestibular system, what will happen is that the opposite side vestibule is still working. So the opposite side will be able to push a lot more, which means that in a case of unilateral vestibular dysfunction, you will have eye movement to the same side, head movement to the same side, and body movement to the same side. So you will have falls to the same side, and you will have tonic gaze deviation. So your eyes will be continuously moved towards the same side as the side of the lesion. Okay, so this is the primary concept of vestibular system. Now, how will this present clinically? The clinical presentation of a vestibular dysfunction is predominantly dizziness. Now, dizziness is a vague term. So dizziness by itself does not mean much. You cannot diagnose a case of dizziness. But dizziness can mean multiple things. So dizziness can mean vertigo. By vertigo, we mean that there is a spinning sensation of the environment. It can also mean unconsciousness or decreased consciousness. So you may have blackouts, you may have fainting spells. You can also have multiple sensory complaints. So dizziness is very vague, but it is part of the challenge of diagnosing a vestibular dysfunction, that you need to understand what kind of dizziness it is. So when a patient says I'm dizzy, what does that mean? Do they have vertigo? Do they have fainting or blackouts? Do they have multiple sensory complaints, or do they have imbalance? Because all of these things will be misinterpreted by the patient as dizziness. So this is how the patient can present primarily. There are associated complaints like nausea, vomiting, and nystagmus. Okay. So there was a study done. They took 100 patients of dizziness, and they found that almost 50% of them had some problem in the vestibular system. Around 16% of them had some psychiatric problems. So they either had anxiety, or they had a panic attack, or something like that. And around 6% of them had pre-syncope. So by pre-syncope, I mean there is decreased blood pressure and decreased perfusion of the brain. So whenever you get a patient of dizziness, you can imagine that this is how the distribution will be. So half of them will present as a case of vestibular dysfunction. All right. So now the main complaint that we have to analyze is vertigo. There are two questions that you need to ask to all patients of vertigo. One is it subjective or is it objective? So an objective vertigo is much more stronger evidence of a vestibular dysfunction. Uh, and by objective vertigo, I mean they can see the world spinning. So whenever they can see the world going round and round, and every time they open their eyes, they can see the world shaking and there is instability in the world, then that is objective vertigo. And subjective vertigo is when they don't see the world moving, but they feel that they are moving. So there is an inner space imbalance or inner space instability. So that is subjective vertigo. Subjective vertigo could also be because of vestibular dysfunction, but objective vertigo has a stronger correlation. Another question you need to ask is it central or peripheral? And of course, this is not a question you can ask the patient, but this is a question you need to ask yourself. Is it central or peripheral vertigo? If there is a problem in the vestibule itself or in the vestibular nerve till it reaches the nucleus, then it is a peripheral problem. From the nucleus up, whether it is in the cerebellum or the midbrain, all of them will be a central problem. And there are fundamental differences between central vertigo and peripheral vertigo. And the main characteristics of a peripheral vertigo or peripheral cause of vertigo is one, it is that the peripheral vertigo, the nystagmus will be fixed. It will be fatigable and fixation will stop it. So these three things I want you to remember, that in case of a peripheral vertigo, there will be nystagmus, and in central vertigo, there will be nystagmus. I'll tell you why there will be nystagmus in a minute. But in a peripheral vertigo, that nystagmus, the direction will be fixed. It will be fatigable. So after some time, the nystagmus will stop. And if you ask the patient to focus on one point, that is to fixate on one point, the nystagmus will disappear. And the central is opposite of all this. In a central nystagmus, the direction is not fixed, it can change. It is not fatigable, it can go on for a long time. And even if you ask the patient to fixate on one point, you cannot uh, remove it. So the nystagmus will continue. Okay. So this is the fundamental difference between central and peripheral. Now, there are other points to look at. So when you're taking history of a patient of vestibular dysfunction and you're taking history of a patient with vertigo, like you take history of any other complaint, the questions you ask is ODP. So you ask for onset, was it acute or is it insidious? You ask for duration, is it short duration or is it chronic? And progress. So is it intermittent or is it continuous? Okay. So why is all of these important? Now, the reason this is important is because you need to know what are the main differential diagnoses, what are the main etiologies that can come with vertigo. So the main differential diagnosis would be, you can have otologic problems. So problems in the ear itself, such as BPPV, so benign positional paroxysmal vertigo. You have something called as Meniere's disease, and there is something called as vestibular neuronitis. So all these three, and these are the three most common causes of ear dysfunction causing vertigo. And the main way to differentiate between these is that BPPV, the onset is acute, the duration is short, and it will be intermittent. Whereas in a Meniere's disease, the duration will be in minutes to hours. Whereas in BPPV, the duration will be in seconds. Okay. And finally, in vestibular neuronitis, it will be a continuous problem. Whereas in both BPPV and Meniere's, the problem will be intermittent. So it will be episodic. So this is the reason why you need to ask these three questions, because that is how you can have an idea as to what can the etiology be. Another question that you need to ask is, in duration, if it has been extremely short lasting, like I said, seconds, it will be BPPV. If it is in minutes, it can be ischemia. So vestibular ischemia is a reason for vertigo starting within minutes. Hours, it is Meniere's, and days can be vestibular neuronitis. Okay. Now coming to the tests, the investigations. How will you test for a case of vestibular dysfunction? So I will be first discussing bedside tests. So you have a patient who's in front of you and he or she is saying that I have vertigo. Now, what do? Overall, there are three things that you want to check, and that is the three connections of the vestibular system. One is the connection with the spinal cord. So you check for vestibulospinal reflexes. You check for connections of the vestibular system with the eye. So vestibulo-ocular reflexes. And you check for connections with the cerebellum. And part of that is nystagmus. So you check for nystagmus. Okay. So these are the three rough headings under which you will test for vestibular dysfunction. So in a case of vestibulospinal, what all will you check? You will basically check for how well the patient is moving their hands and their legs. One important test is called as past pointing. And the way you do this is that you make the patient stand and one hand is below, and then the other hand is raised, and you stand in front of the patient, and you ask the patient to bring down the hand and touch yours, and then pull it back up again, and then bring it down again and put it back up again. So continuously, the patient has to bring the hand down, touch your hand with his, and then bring it back up, but with the eyes first open and then closed. Now, what will happen? With the eyes open, the patient will be able to bring down the hand, touch your hand, and then put it back up, and then bring it down again. So with the eyes open, it should not be a problem because your eyes are compensating. But once eyes are closed, then the body depends on the two vestibular system to tell you where the hand is and is it moving left or right, and is your body turning left or right. And as soon as the eyes are closed, the hand will start deviating towards the side of the lesion. So if there is a right-sided vestibular dysfunction, the hand will start deviating towards the right because the left is pushing. So that is called as past pointing. There is another test called the stepping test. The stepping test is done by asking the patient to step up and down on the same spot. So the patient will step up and down on the same spot and keep the eyes closed. So in a normal person, he will be able to step up and down, just do a march past on that same spot, and there will be no issue. But in a case of vestibular dysfunction, gradually, if there is a right-sided problem, the left side will push. So gradually the body will turn towards the side of the problem because the normal side is pushing it. Now this test is also known as Unterberger Fukuda test. And the concept remains the same. If there is a dysfunction on one side, the normal vestibule will push, and so the entire body will start turning towards the affected side. Another interesting test is known as star walking. And in this, you ask the person to walk front and back in a straight line, okay, and with the eyes closed. So here in this case, what will happen is that in a normal person, he should be able to walk front and back in a straight line any number of times, and there will not be too much deviation. But in a case of vestibular dysfunction, the person will walk to one side, and while coming back, he will slightly deviate. And then again, while walking forward, he'll again deviate, and then again deviate, and again deviate, and so on. And so by the end of 2-3 minutes, he, instead of walking in a straight line, he would have made a star. So this is known as star walking test. These are all vestibulospinal. So how coordinated is your connection from the vestibule to the limbs, to the hands, to the legs? This connection is via the vestibulospinal tract, and these tests will test for that. The next aspect is your vestibulo-ocular. So in this, what all do you test? One is your doll's eye test. Now you may have heard of doll's eye test. The concept of doll's eye is that in a patient, the vestibular system connects to the medulla and the midbrain. And the midbrain and the pons will control the eye movement. So if your head turns to the right, eventually your eyes should also turn to the right, unless your eyes are fixed on a particular point. So if your eyes are fixed, so if I tell you to pick a spot in front of you and then turn your head right and left, you will be able to maintain your eyes in that position. But supposing there is cortical damage. So supposing there is a large infarct or there are multiple infarcts, or there is some reason for unconsciousness and there is cortical damage, you want to know whether your brainstem is spared or not, you do the doll's eye test. And in the doll's eye test, with the head movement, if the eyes stay, so if I turn the head to the right, the eyes should go to the left initially and then slowly move to the right. So that is called as doll's eye test. And that indicates that this circuit is normal. So the circuit from your vestibular system to the medulla to midbrain and pons, that circuit is normal. So that means that there is no, or rather there is less likely to be brainstem damage. Whereas if your doll's eye is absent, so as soon as you turn your head, your eyes are also moving with it, that means that there can be brainstem damage. Now, this can only happen in a patient with cortical damage. So your eyes are, your cortex is not working. Supposing if the patient is alert. In an alert patient, the version of doll's eye is called as head impulse test. And head impulse test works in the same way. Now, I will ask the patient to look at a particular spot straight ahead, and the patient will have to look at a particular spot, and I will turn the patient's head to the right and to the left. And in either direction, the eye has to move to the opposite side in order to maintain fixation. So if I am looking at the screen and I turn my head to the right, my eyes have to turn to the left. And this has to happen spontaneously, and it has to happen at the same speed. It cannot be at a higher speed or a lower speed. And if this is happening, then that means that my vestibular system is working. Supposing there is a problem in my vestibular system. So supposing there is a problem in my left-sided vestibular system. So the left is supposed to push my eyes to the right. So now, if I turn my head to the left and there is a problem in the vestibular system, my eyes will not turn to the right. My eyes will instead turn with my head, it will turn to the left. And now my cortex, my frontal lobe, will remind me that I have to look at the target. So now, because I have turned my head to the left and my left vestibule is not working, my eyes have also turned to the left. So instead of keeping my gaze fixed at the target, now my gaze is here. And so my frontal lobe has to voluntarily shift the gaze back to the target. And this is known as a correction saccade. And this is seen as a nystagmus. So it is a fast movement. So there is if I turn my head to the left, there is a correction of my eyes back to the target. And that can be seen because of a frontal lobe correction. So that is called as head impulse test. And finally, there is something known as caloric test. Now, you may be familiar with the caloric test, especially in terms of brain dead patients. So how do we test for brainstem dysfunction? So caloric test, the fundamental concept is that if you inject cold water, it acts as a destructive lesion. And if you insert warm water, it acts as a irritative or a stimulant lesion. Okay, so what does this mean? If I put cold water, it acts as destructive. So that means that if I put cold water into my right vestibule, so if cold water is put into my right vestibule, then my right vestibule will stop working. So then the left vestibule will push. And if I put warm water, then it will act as an irritant. So now the right vestibule will work more. And so the right vestibule will push to the opposite side. Okay. Now, what will happen? So supposing if I insert cold water into the right side, now the right vestibule isn't working. The left vestibule is working. So the left vestibule has pushed. Now again, the frontal lobe will convince my eyes to move to the opposite side. And it will be a quick movement. And that is why when you insert cold water, what you actually see is this quick movement to the opposite side, which is why they say that when you in cold water, the movement is opposite. Now, similarly, if I put warm water, it will act as an irritative, so there will be excess movement. Now, the initial movement will be towards the left, and now the frontal lobe will move it to the same side. So when I put warm water, the fast movement will be towards the same side. This is why there is a mnemonic called as cows. Cold is opposite and warm is same. This refers to the frontal correction, not the immediate movement. So the immediate movement will be a tonic deviation to the, if it is a destructive lesion, it will be a tonic deviation to the same side. And if it is an irritative lesion, the tonic deviation will be to the opposite side. Whichever side there is a tonic deviation, the frontal lobe will correct it. And it is that correction that you can see visually. And so it is that correction that we are remarking on when we say cold opposite, warm same. There are some electrophysiological tests that you can do, mainly electronystagmography. And the benefit of electronystagmography is that it is a way of quantifying the nystagmus. Couple of things about nystagmus itself. I don't want to go too deep into nystagmus because it can get it's a very deep topic, but in vestibular system, remember that the nystagmus has a slow component and a fast component. The slow component is because of the vestibule itself. So whichever vestibule stops working, the other vestibule will push, and that pushing will be a slow component. And the fast component is because of a frontal correction. So if my eyes are slowly deviating to the right, because my right vestibule is not working, my frontal lobe will quickly correct it back to the left. Okay. So the correction is a fast component, and then there'll be a slow component. So every nystagmus has a fast component and a slow component. Second is that the nystagmus can be spontaneous. So while just sitting, there may be nystagmus, or it may be positional. That is called as Dix-Hallpike maneuver. Spontaneous versus positional. In positional, there is something called Dix-Hallpike maneuver, in which we make the patient supine. So if the patient is sitting like this, we ask the patient to become supine, and we bring down the head by 45 degrees. So now the head will come down here, and we will also turn the head to one side by 45 degrees, so that there is one ear is dependent. So one ear is towards the ground. And that is one way to diagnose if my right ear, my right vestibule has a problem, and my right vestibule is towards the ground, there is a bigger chance of me getting an attack of vertigo. So you can diagnose that the right side is the problem or the left side is the problem, depending on whichever ear is dependent, and I'm getting an attack of vertigo at that time, that side is involved. And spontaneous nystagmus is not positional. There are three grades to it. The first degree of nystagmus is when your eyes are turned away from the side of the lesion. Second degree is when you are looking straight ahead, and third degree is towards the side of the lesion. idea is that you can have spontaneous nystagmus or positional nystagmus. Positional nystagmus is better, and it is also helpful in diagnosing which side is the lesion. Now, in a case of vestibular dysfunction, the approach is the same as all the other cases: where, what, and why. Now, the patient has come to you with one of these symptoms. So, vertigo, dizziness, imbalance, nausea, vomiting, okay, all of these. We need to know where is the lesion. And in where is the lesion, our differential diagnosis is it a cerebellar problem? Is it a vestibular problem? And if it is a vestibular problem, is it a central or a peripheral? There are some key features in peripheral, because if it is a peripheral lesion, that means that your ear is involved. And if your ear is involved, there will be other things such as earache or ear discharge, hearing loss, there may be tinnitus. So these are all aspects of peripheral dysfunction that you can use to diagnose that this is a peripheral case and not a central case. And in a case of central problem, it can be long lasting. So it is not, like I said, it is not fatigable. Then coming to what is the lesion? So now that we have diagnosed, supposing we diagnose that it is a peripheral vestibular problem, then we talk about what is the lesion. So the what is the lesion can be that it is a destructive lesion or an irritative lesion. And the way we find this out is that if a destructive lesion, the other side will push, and an irritative lesion, the pathological side will push. And then coming to why, the main causes of vertigo, the main causes of vestibular dysfunction is BPPV, Meniere, and neuronitis. And there are a couple of vestibular nerve problems. So one of them is a schwannoma. So acoustic schwannoma or a CP angle tumor. Now, there are a lot of central causes of vestibular dysfunction. So such as you can have stroke, multiple sclerosis, tumor. The stroke can be in the cortex or in the brainstem. You can also have drugs. Now, it's important to mention drugs because drugs is one of the few causes of bilateral vestibular dysfunction. So everything that we have discussed so far, we have talked about imbalance. We have talked about if one side is normal and one side is abnormal, so then the normal side will push. But in a problem of drug toxicity, like ototoxicity, so if you take streptomycin or gentamicin, those drugs will cause vestibular dysfunction and they will likely cause bilateral. Why should it cause only one side? So then both sides will be equally gone. Then you will not have all of those issues. So you will not have your nystagmus, you will not have any signs of one-sided dysfunction. The main thing you will have is imbalance in walking, which will be bilateral. So that covers our approach to vestibular dysfunction. Management completely depends on the cause. If it is a stroke, then you'll manage a stroke. If it is multiple sclerosis, then you will need to give immunosuppression. There are symptomatic medications that you can give, beta histamine, etc., that you can give, and dicyclomine for vomiting. But the important thing is to find the cause and treat the cause. One line on BPPV specifically. The concept of BPPV is that within the vestibular system, I mentioned that there are semicircular canals, utricle, saccule, and then the vestibular nerve. And within the within the system, there are hair cells. Now, what happens is that you get otoliths. So within the endolymphatic fluid, you can get otoliths. So otoliths are small stones, and as your head moves, these stones will also flow along with the endolymphatic fluid, and sometimes they get lodged in a particular point, and it will hinder the flow. So now what will happen is that because flow is hindered on that side, the communication isn't happening. So your brain isn't understanding why is there movement on one side but not movement on the other side, because both your vestibular systems are working in symmetry, like working hand in hand together. So if there is a block on one side, then that will immediately cause vertigo, because it is sort of like a disturbance in the connection, disturbance in the signal. So because your brain isn't able to make sense of it, you get a perception that the world is going upside down or it is turning very rapidly. What happens is that if it persists, after a while your brain gets used to it and it starts to make corrections. So if it persists for a long time, your brain starts to ignore that part of that signal, and then your vertigo decreases. The one of the treatments for this is that you teach the patient a maneuver called as Epley's maneuver, in which the patient himself is able to maneuver the head in a way that the stone gets dislodged. So then as soon as the stone gets dislodged, the symptoms will relieve. Okay, so that is BPPV. I think that's about it. Now I'll just answer some questions. So presence of correction saccade in head impulse test is normal? No. You should not get correction saccade in a head impulse test. In a normal person, you will ask the patient to focus on your nose, and the person will keep focusing on the nose, on the examiner's nose, and when the head is turned to one side, the eyes should immediately move in the opposite direction. There should be no lag, because the connection between the vestibular system and the ocular system is so strong that even as you start moving your head and neck, your eyes will start moving. There is no lag between them. If there is a lag, that means there is a problem in the vestibular system. So if your eyes move with the head and then it corrects back, that means that there is a problem in the vestibular system. Oculocephalic and VOR remain, yes, oculocephalic and VOR, yeah. Vestibulo-ocular reflexes is the large term for it, is the umbrella term for it. And one of the vestibulo-ocular reflexes is oculocephalic reflex. So oculocephalic reflex is doll's eye, and vestibulo-ocular reflex tests. One of the vestibulo-ocular reflex tests is doll's eye test. Another one is head impulse test. So doll's eye is in an unconscious patient, and head impulse test is in an alert patient. Both of them have the same concept. What is the connection between PPRF and vestibular nucleus? So suppose this is midbrain, this is pons, and this is medulla. These four are the vestibular nuclei. The PPRF is in the lower pons. So this is the PPRF, and this is the sixth nerve nucleus. This is sixth, this is PPRF, and this is vestibular nucleus. Now, there is a medial longitudinal fasciculus on both sides. And you have your cranial nerve 3 and cranial nerve 4 nuclei here. When we discussed eye movement, we discussed how the signal will come to the PPRF. From the PPRF, the signal will cross over to the opposite medial longitudinal fasciculus and then go up and talk to the cranial nerve 3. That is how your eyes are moving. But for this, when I tell you to look to the right, you can look to the right, but for this movement, you need information of your head. You need information as to which direction are you oriented. Is your head straight or turned or what? So that information comes from the vestibular nucleus. So the vestibular nucleus also talks to both the PPRFs. There is an intervening nucleus known as NPH. So nucleus prepositus hypoglossi. So via the NPH, they will talk to the PPRF, because you need continuous information by millisecond information uh, as to whether your head is moving or not, whether are you accelerating or decelerating, are you turning upside down. So that information needs to come continuously. So, and because your PPRF is responsible for eye movement, your vestibular nuclei are continuously talking to the PPRF. Having doll's eye means having an intact oculocephalic reflex or an abnormal one. Yes, so doll's eye present means brainstem intact. Doll's eye absent means brainstem problem. Okay, so you don't say doll's eye in an alert patient. So if a person is conscious, then you don't comment on doll's eye. Then you do head impulse test. But if a person is unconscious, then you comment on doll's eye, because you want to know, is it just the cortex gone or is it cortex plus brainstem gone? Peripheral versus central nystagmus. Regarding peripheral and central nystagmus, the main differences are that your central nystagmus is usually a pure one. So by pure, I mean that it is either upbeating or downbeating or torsional or horizontal. So it is in one direction and it is continuous, whereas peripheral can be mixed. So it can be horizontal plus torsional, or it can be vertical plus torsional. It is very rarely perfectly horizontal or perfectly vertical. And the reason for that is that there are so many different angles that it is never perfectly horizontal or vertical. It is always usually at some angle. So because of the orientation of all the semicircular canals, if there is a dysfunction in one of them, the resulting nystagmus will always be a mixture of vertical and horizontal or torsional. Whereas in central, it can be a pure one. All right. Hello. Thank you all. I will see you on Sunday. We will be discussing anxiety and panic attacks on Sunday. Thank you so much.